Ujjwal, a second-year resident physician at St. Vincent Hospital in Worcester, Massachusetts, and I'm grateful for the opportunity to present our QI project. As we know, falls are a leading cause of death, morbidity, institutionalization, and overall economic costs. And it is also difficult to conduct a randomized control trial on fall prevention. So in our project here, we provide qualitative real-world data from our institution, specifically from our resident-run clinic. I want to introduce two clinical tools here. The American Geriatric Society Beers criteria is a list of medications that are thought to be potentially inappropriate. These are called PIMs, and they cause harm by drug interactions, functional impairment, as well as worsening comorbidities in the patient, and can be used for shared decision-making. The second tool is the Hendrick Fall Risk Model, which is actually a screening tool we use in our clinic. And this will give a score to the patient based on their pre-existing medical condition and use of concurrent medications. And a score of 5 or more is considered high risk. For our clinical objectives, we aim to identify the prevalence of PIM use, identify if fall risk assessment was done and documented, and identify strategies for improving fall prevention. We did a retrospective chart review of 160 patients who came to our resident-run clinic between 2022 to 2023 and collected data on demographics, type of medications, fall episodes, and strategies for preventing falls. So we found that 51% of our patients were actually taking these PIMs, and we found that 8 of those patients actually suffered a fall as compared to no patients in the non-PIM group who suffered a fall. We identified 3 strategies for reducing falls. The first one is assessing the fall risk using the HFRM2 tool, and this was utilized in 77% of patients. And then the other 2 strategies were actually counseling the patient about fall risk when they were prescribed high-risk medications. This was only used in 9% of cases. As well as de-escalation of pharmacotherapy was only done in 6% of cases. So this shows the potential for improving fall prevention by utilizing these 2 strategies. In conclusion, we think that fall risks will depend not only on patient factors, but also extrinsic factors like the environment, the type of activity, as well as these medications, which are actually a reversible cause of falls. And so we want to educate residents about Beers criteria, proper indications and adverse effects of medications, empower them to have discussions about de-escalation or de-prescribing, as well as improve nurse to provider communication about high fall risk as soon as HFRM2 is documented. And we also want to use the right medication for the shortest period of time and utilize our pharmacy funds in weighing in on drug-to-drug interactions and doing a good medrec at the time of a hospital follow-up visit. And for our patients, finally, we want to advise diet, strength training, and refer them to physical therapy, eye testing, or home environment evaluation as indicated.